My title was Lupus and Vasculitis, the Cause of TMA in Pregnancy. I'm not going to talk about vasculitis. Vasculitis is pretty rare, actually, in pregnancy. We hardly see it, largely because it's a disease that affects older people, rarely presents new. And vasculitis and TMA, I think, is vanishingly rare. So I'm afraid I've just ditched that bit of the title. Diagnosing, and a lot of what I've said has sort of been heralded by the previous talks. Diagnosing TMA in pregnancy in patients with lupus. There are things that should make you suspicious. They have a TMA, if they have low platelets, hypertension, if they've got microangiopathic hemolytic anemia. But of course, some of the key clinical features of lupus, especially with nephritis, are low platelets, hypertension, and a hemolytic anemia. So it isn't actually that clear cut. And most of the data, a lot of data is from non-pregnant patients. And if you think about how common are these features that we associate with a TMA in people with lupus, this was a very recently published systematic review actually looking at the differences in clinical features between children and adults with lupus. But just looking at the adults, thrombocytopenia is incredibly common, 24.8%. And I always teach, look at the blood count if you're looking whether this patient's got vasculitis or lupus is the cause of their acute renal dysfunction on Friday afternoon. If they're it's much more likely they've got lupus. Hemolytic anemia, not a microangiopathic hemolytic anemia, but hemolytic anemia, 13.8%, and renal involvement's very common in 44%. And these things, in a way, are not uncommon, and certainly I would say thrombocytopenia is no less uncommon in pregnancy. The only reason these things should be much less common in pregnancy is in the ideal world, you've made the diagnosis, treated the lupus, and the woman goes into pregnancy with completely controlled lupus, and their platelets have recovered and their renal function's good, etc., etc. But of course, as you all know, that often doesn't happen. I've got a colleague in Brazil, Roger Levy, who says that planning isn't a word his patients understand. That's not entirely fair. And of course, some women present for the first time in pregnancy. Really, from my perspective, how you would diagnose a TMA is on the renal biopsy, but actually it's often not done in this setting. They're pregnant, people get anxious about biopsy in pregnancy. They've got low platelets, which increases the risk of bleeding, which makes them more anxious, and then they're hypertensive, so it all becomes a bit of a no-no. And then there's a bit of a variation on how you define the thrombotic microangiopathy. Tabby Turner-Stokes is one of our fellows at Imperial, and she's actually just published a study looking at ANCA in patients with lupus. But as part of that, she went right through a large series of renal biopsies that we have in all those who have been tested for ANCA. So there were 200 biopsies she reviewed, and she actually looked, actually at the request of the referees, but it's quite useful for this, at the vascular changes in these patients. And looking at all of them, not just those who were ANCA positive, 5.5% had arteriolar hyalinosis, 4% had arteriolar intimal thickening. Arterial hyalinosis was rare. Arterial intimal thickening was seen in 40%, but I suspect in a lot of them that's due to poorly controlled hypertension secondary to their renal disease, not a good finding, and vasculitis is actually very rare. What we often get asked by our pathologists is they look on electron microscopy, which isn't required for the diagnosis of lupus nephritis, but we always do and is incredibly useful. And if they see subendothelial rarefaction and interposition of cytoplasm, they'll say, look for the antiphospholipid antibodies, and we never find them. So if you look at other series of looking at thrombotic microangiopathy and lupus biopsies in the non-pregnant women, there's a recent retrospective study of 429 biopsies from Mexico City. I have to say the numbers of lupus patients they're seeing is quite extraordinary. And they defined it on light microscopy, luminal narrowing of the vessel caused by eosinophilic, this is TMA, diagnosed by eosinophilic and fusinnophilic deposits with staining for fibrin associated with endothelial edema and luminal thrombi, and they called that acute TMA. And then they looked at chronic TMA, which was really vascular changes, and they only saw proper TMA in all their 429 biopsies in 5.4% of patients. But they then looked at the clinical features of those patients. They looked at various vascular lesions compared to those with no vascular lesions. And if you've got a TMA, you're much more likely to have what we call a rapidly progressive glomerulonephritis, so a rapid falling off of renal function. You're going to be hypertensive, this is mean arterial pressure. You're slightly more anemic. Your platelet counts weren't that low, much higher than, say, with TTP. Creatinines were much worse, with a concomitant much worse GFR. There was a higher proportion of them who were lupus anticoagulant positive, but not the majority by any means. And they were much more likely to have a proliferative lupus nephritis associated with this. And actually none of those with TMA had a membranous lupus nephritis. What's worrying is if you look at patients with no vascular lesions compared to those who've got a thrombotic microangiopathy, this is percentage renal survival over time from 100% to 40% down here. And you can see by 5 years there's much worse survival of those with a TMA, whether it's chronic or acute. And this is actually with atherosclerotic lesions. So the fact that so many of our patients have got atherosclerotic lesions is bad news for them and outcomes. We've also looked at another way. Kate with Phil Webster recently published looking at women who'd either had biopsies during pregnancy, which is the minority, or those within a year of delivering, to see what the diagnoses were and whether there were differences. And there's a sort of whole separate piece of data that comes out of that. But actually TMA didn't figure in that year postpartum in a large number of biopsies. So it's not a common diagnosis in our hands. Coming back to the PROMISE study, which I think has defined what reasonably well-controlled patients with lupus should expect during pregnancy. As was already mentioned, it was 385 women. It was a prospective study in the USA and Canada, multi-ethnic, multiracial, and they looked at, and these were well-controlled women, and they went for hard endpoints, which they defined as adverse pregnancy outcomes, APOs. And these were premature births, but not just because the doctors were getting a bit antsy, but due to gestational hypertension, preeclampsia or placental insufficiency, fetal death during the second or third trimester, infant death related to pregnancy problems, or proper small for gestational age, a birth weight less than the 5th centile. They only included women who they deemed as having inactive lupus, and they defined that. They excluded those with a urinary PCR of less than of more than 100, which is about a gram a day. If they had a creatinine above 106, it's an odd number because it's translated from the American, as it were. If they were on more than 20 of PRED, and if they had multiple pregnancies. So these are women who may well have had lupus nephritis, but have had it well controlled. And they were nearly all on hydroxychloroquine. And the things that predicted a bad outcome were those with more active lupus disease, high blood pressure requiring medications. That I find slightly difficult. Many women who've had lupus nephritis will be on blood pressure medications to reduce their proteinuria, not because they're actually hypertensive. And I don't think that was teased out. And I'll come back to this, a positive lupus anticoagulant. And during the second and third trimester, the more active their disease and if they had a flare. This is the key data, I think, for today, because I'm not sure that we aren't missing. I don't know whether this is telling you about lupus, whether this is just telling you about complement activation in lupus, or whether we're missing some level of TMA in these patients. There's a consistent message that being lupus anticoagulant positive is very bad for you in pregnancy, but actually low platelets also predict adverse pregnancy outcomes. So these are 3 groups of women here that they focus on. They had 129 women who were non-Hispanic white, who were not on any antihypertensives, who were lupus anticoagulant negative, had a physician's global assessment score of less than 1, which means you think they're very well. Platelets at least 100. And only 7.8% of those had adverse pregnancy outcomes, so relatively low risk. And you can identify those patients in your pre-pregnancy clinics and say, I think you're going to do fine. And they had relatively low rates of fetal or neonatal death. If you took the group of 50 of the women who were LAC positive or LAC negative, but non-white or Hispanic, on antihypertensives, their adverse outcomes went up to 58% from 7.8%, and fetal or neonatal deaths were 22%. If you took this rather grim group of 8 women who were LAC positive, who weren't looking very well, who were on antihypertensives and had platelets less than 100, they all got, 7 out of 8 of them had adverse pregnancy outcomes. So you can definitely, from the PROMISE study, identify high-risk patients, but there's this very worrying group, and I worry if they are actually the ones who've got much more going on than your bog standard lupus, and whether they've got some form of TMA going on. So if you have a patient with lupus who's pregnant and whose platelets fall, your question is it lupus? Does she have lupus nephritis? Does she have a TMA? I have to say I don't often ask that. And is it her immunosuppressants? Because anything we give, azathioprine, that can reduce your platelet count. Tacrolimus can actually cause a TMA, so you have to think about that. The usual question we're asking is not, is this a TMA? We're saying, is this preeclampsia? And it's quite difficult to differentiate the two. A lot of the symptoms that you might associate with lupus are present in pregnancy. That's not good. Present in pregnancy, hypertension, proteinuria, thrombocytopenia, renal failure, but lupus has serology to go with it. So if they've got a rising DNA, if their complement's falling, pregnancy is an acute state response. So they often have a rise in their complement. If their complement's falling and still in the normal range, you should still worry about the trends, and we measure it monthly. And if they've got a combination of a falling complement and a rising double-stranded DNA, that should make you very worried. And they tend not to have abnormal liver function tests. So what might discriminate TMA from a lupus flare? And I think it was Lucy who showed this sort of slide earlier on, and they're impossible because there's all 2 pluses and 1 pluses. And actually this is from a recent paper from Vesna Garovic and Belinda Jim. But the only thing on that which actually truly differentiates atypical HUS from lupus of flare in pregnancy is the presence of fragments on the blood film. You shouldn't see that in a standard lupus. And if they've got a MAHA, then they've certainly got a superimposed TMA. It doesn't mean they haven't got lupus, but they haven't got straightforward lupus. And it is important to distinguish because lupus we largely treat by immunosuppression, and I've realised I've sort of left out a key bit of slide. Yes, we give aspirin. Everyone who's got renal disease gets aspirin to reduce their risk of preeclampsia, which is increased because they've got renal disease. So I sort of almost don't think about it. All my lupus patients get hydroxychloroquine. So they're all on aspirin, hydroxychloroquine. Many of them are on low molecular weight heparin because they've got significant proteinuria. They've got an increased risk of thrombosis, and they're pregnant. They've got increased risk of thrombosis. So they go on to a low molecular weight heparin, and that's sort of standard. But we would immunosuppress someone with lupus. I tend to try and minimise or avoid steroids, so I use a lot of tacrolimus, which of course can cause a TMA. There was a recent case report which was quite interesting because it was a biopsy-proven TMA in a patient with lupus who had thrombocytopenia and had their thrombocytopenia treated with romiplastim, which is one of these thrombopoietins. And she got a nasty TMA, and they've actually postulated it was due to that. I shall leave the haematologist to argue about that. But she did not have a lupus glomerulonephritis. There were no other drugs. And I thought it was quite interesting. And they treated, and we would treat a proper good-going TMA with plasma exchange, even possibly eculizumab. So eculizumab, of course, is a very interesting drug, not least for its price. And there are some case reports. There was, as far as I understand, a trial done many years ago by Richard Fury, but it's never been published. There are some case reports, including one from us, and there's been a systematic review of those just recently. And actually, I think it's 6 cases. It's 6 publications, but I think it's 6 cases. 3 with biopsy-proven lupus nephritis, 2 with antiphospholipid with no lupus nephritis, and our patient who had a really refractory lupus nephritis. And all had severe renal impairment. Our patient was heading for dialysis and low complement, and they all improved with eculizumab. Now, this wasn't in pregnancy, but eculizumab has been used in pregnancy in other conditions, so it is a drug we consider using. Of course, you worry about publication bias because people like to publish their positive results, but actually, because eculizumab is so expensive, I expect people would publish whether it worked or not, but you never know. So I think, you have, when you're looking at the patient in front of you, you're sitting there saying, what's the predominant feature? And I do wonder how much TMA we're missing. The proper HUSs that appear to occur in lupus patients are usually associated with proper complement abnormalities. You can get renal limited disease with nothing on the periphery. I think if the patient's got severe hypertension, falling platelets, and particularly if they've got fragments on their blood film, you would definitely think there was an associated TMA, whether it was pure or part of a lupus nephritis. But most of the patients will actually have lupus nephritis and preeclampsia. And I just want to finish with a couple of cases to say it gets more difficult. So I was I pulled out this case for another talk I'm giving in a week or two, and I looked at the biopsy and thought it was very odd. So this is a 36-year-old African woman who presented to us 18 weeks pregnant with nephrotic syndrome. And she was very nephrotic. She had 10 grams proteinuria, serum albumin of 42, wonderfully normal creatinine, and her histology was initially unavailable, but subsequently came back ANA positive, DNA negative, normal complements, and subsequently lupus anticoagulant and anticardiolipin antibody negative, but she is anti-RMP and SM positive. And her biopsy, I don't know how well this projects, but a biopsy shows that she's got some capillary loop thickening, she's got some mesangial proliferation, and she's got some holes and spikes on the silver stain. She's got class 5 lupus nephritis. She's also got an awful lot of capillary microthrombi. Now, of course, the report from Terry said, please exclude an antiphospholipid antibody. And she hasn't got one, and she's never had one. She got completely better. She went into remission more or less through pregnancy, and postpartum she's in complete remission, just with tachinase and a couple of pulses and methylpred. She was a bit hypertensive, but nothing horrible. But that does make me quite worried. And I don't know if that is just because she was very prothrombotic, because she was so nephrotic, or whether she's got an underlying TMA. And there was some there were subepithelial deposits, and there was endothelial cell swelling on her biopsy. And just this is the more typical patient that we see. This was a young woman, Chinese origin, who presented elsewhere in pregnancy at 22 weeks or 24 weeks with severe preeclampsia and thrombocytopenia. And she lost the baby in that first pregnancy, and she was noted to have persistent thrombocytopenia, was actually thought to have lupus. She didn't present to us till about 6 months later, when there was no question. She had hemolytic anemia, thrombocytopenia, acute severe renal involvement. She had a creatinine that had risen to 120, her albumin was down at 18, and she had a proteinuria of sort of 17 grams. And this was her initial biopsy, and she actually has a very proliferative lupus nephritis with crescents. And because she wanted to get pregnant, she went into remission very quickly with our steroid-sparing regimen. She never had any oral steroids, but she wanted a repeat biopsy. So we did a repeat biopsy 70 weeks later when she was in complete remission, and you can see she has almost normal glomeruli. She had no evidence of a TMA on biopsy. She did have massive immune deposits here. You can see subendothelial, and she's also got them subepithelial here, and she had complete resolution with just intramembranous deposits 71 weeks later. And she did very well. She had one small renal flare, which we retreated. She had one hematological flare, which we treated with methylpred and rituximab. And interestingly, she then went on to have a successful pregnancy. She became thrombocytopenic again, and all we did was give her 2 weeks of oral steroids to bring up her platelets so that she could have an epidural and have a baby. And she had that successful pregnancy, repeated it last year. So she's had 2 successful pregnancies, both with marked thrombocytopenia. I'm sure she doesn't have a TMA. She's got preserved renal function, and I'm rather proud of the fact she's never had renal steroids. I would like to take the opportunity to remind everyone in this audience that there is a CKD in pregnancy rare disease group. It's part of the renal registry, and all women, it's very easy to register patients, all women who are pregnant who have any renal disease, CKD 1 to 5, so lupus would count if they've got renal involvement or previous renal involvement, should go on the registry, because it's the only way we're going to get prospective data that we can mine and go back, say, and look at the biopsies. And these are all the wonderful people I work with. Thank you very much.